Hello, and welcome to this lecture on amputations. Before we embark on the rehabilitation of amputations, you need an introduction to the fundamental aspects of the medical rationale for amputations. By medical, I also mean to allude to the surgical aspects. But to appreciate the medical surgical aspects, we need to begin with a brief history and epidemiology. We need to discuss history because it shows us change, how a progressive science constantly evolves. We need to discuss epidemiology because it shows us how disease and disorder affects masses and how it can be mitigated by healthcare workers looking beyond the immediate patient. This is a historical image. It depicts a war zone where it was imperative for doctors to amputate limbs of soldiers injured by ammunition balls and bombs right on field before gangrene and necrosis would threaten the life of the patient. In a time when there was no anesthesia prior to the discovery of ether, the only option was to make the patient drink alcohol, and a group of assistants to the physician would hold the patient down as their limbs would essentially be hacked straight off with crude saws of the times. We will study amputations to cover these important objectives. Let's get started. Amputation is defined as the transosseous removal of all or part of a limb or body appendage by deliberate surgery or trauma. It is one of the oldest known surgeries. The history goes back more than 2,000 years. Amputation, in its way, is the final surgical frontier. After all possible limb salvage options have been exhausted, which means that everything that could have been done to save the limb has failed. Disarticulations, on the other hand, is the process of transarticular removal of the extremity or part. For purpose of this session, both the terms amputations and disarticulations are synonymous. Specific differences will be pointed out, and they pertain primarily to surgery and future prosthetic abilities. A little before the discovery of ether, uh, the process of amputations was essentially severance sans anesthesia. That meant that patients would get amputations with no numbing and no pain relief. Hemostasis is the process of stopping the arterial bleeding immediately after incision. In the earliest days, this was achieved by dipping the stump in hot oil. Today, this is achieved by electrocautery. In reference to the prosthetic probability, the stump of yesteryears was poorly adapted for future prosthetics, and the mortality rate was high. We'll look at epidemiology now. What is most surprising is that there is no national database in the United States for amputees, none. In 1996, the National Health Interview Study, or NHIS, was the most comprehensive data on amputations and people living with limb loss. It is estimated that the number of people with limb loss in 2005 was 1.7 million. That is almost about 1 in 200 people. And the numbers will double by 2050 if the causes of amputations are not adequately controlled. The annual figures uh, of amputations is estimated at 185,000 per annum and growing with increased lifespans. That means people with amputations are living longer. The risk factors and etiologies are multiple, and there are many causes that would lead to amputations. However, some are more common than others. In 2009, the hospital costs associated with amputations was about 8.3 billion, or even more than that. African Americans are up to 4 times more likely to have an amputation as compared to white Americans. People with amputations due to vascular etiology will see up to 50% of them die within a course of 5 years. This is higher than the 5-year mortality of a number of other deadly disorders such as breast cancer, colon cancer, and prostate cancer. People with unilateral amputation due to diabetes will see that up to 55% of those will require a second amputation of the contralateral leg within 2 to 3 years. The epidemiology of lower extremity amputations varies between developed and developing countries. In the developed countries, the first world, the incidence of lower extremity amputations is highest for people with disease that leads to amputation requirement. In contrast, trauma occupies a much lower level of rationale or etiology for amputation. The other causes of amputation in the developed world are relatively minor. If you compare that with the epidemiology of lower extremity amputations in the third world countries, the biggest reason for amputation in third world, up to 90% actually, is trauma. And this trauma is both road traffic accidents, but more so uh, uh, because of war injuries, landmines, and bombs. Disease and congenital malformations are relatively much less as a cause of amputation in the third world. This slide shows you a worldwide epidemiology at a glance. So, and in this slide, this is the summary of the epidemiology discussed so far. We'll now look at the etiology and indications of amputations. Colloquially speaking, the cause of amputations can be distilled into the 3Ds. First D would be for dead, or a part of the body which is either dying or is completely dead. This could be equated to conditions like gangrene and necrosis. And then there is a body part which is dangerous if it is left in the body. So that would be the second D. A body part that is a nuisance. So this is an easy way to remember the issues surrounding amputations or the causes. So here are some examples. Examples of dead body part are shown on the screen. It's severe trauma with gangrene or somehow the body part is completely dead. Example is shown on the picture. You will notice that the physicians will create what is called the line of demarcation to see whether it is getting better or worse. This is an example of a dangerous situation where the body part is so mangled that it cannot be saved. Examples would be malignant tumors, potential lethal sepsis, crush injuries, as is shown on the screen, and then sometimes a forgotten tourniquet. A tourniquet is used to create bloodless surgical fields, and if it is left in place for more than 6 hours, it will be grounds for amputation because the part would have suffered from an anoxic injury that cannot be reversed. This is an example of a malignant proximal humerus tumor which is not operable and will need to be amputated. Uh, and it is kind of interesting to use a term like damn nuisance, but here is an example of that. This is a real picture of a baby born with too many toes, and these are a nuisance to live with. And in this case, some of those toes will be cut off, and that is why the use of the term. Any gross malformation, as in arthrogryposis, multiplex congenita, or phocomelia, um, in polydactyly, or a body part which is repeatedly causing sepsis. These are examples of dam nuisance. Okay, so this is explaining to you the causes of amputations without having to remember many difficult things. So you can just go, oh, those are the 3Ds. But formally speaking, we can actually use a different classification, and we will talk about that. So these are specific diseases and disorders in which amputations occur. Will not other conditions that require amputation. So these are risk factors that contribute to amputation. CVA, a prior major amputation can be a cause for amputation. Okay, uh, in upper extremity, um, the primary cause of amputations is trauma. Okay, many different types of trauma, but trauma. It can be congenital, it can be disease related. Um, The problem is that initially the attempt is made heroically to try to save the limb, which is called salvage surgeries. And these salvage surgeries can continue for years, and eventually it will lead to amputations. Regardless of etiologies, there is one absolute indication for amputation, and that is irreparable vascularity. If the vascular supply is such damaged that it cannot be retrieved, then that is a cause for amputation. So let's look at some surgical considerations in amputation. The ultimate surgical goal of amputation is to produce what is known as a physiologic end organ. The remaining stump must be physiologic, which means it needs to be able to be incorporated with a prosthetic device. Now, it is important to realize that that is a goal. Not everybody will become a prosthetic user, but at least the limb should be shaped in a way that it can accept a prosthesis, and that is what it is referring to as a physiologic end organ. So essentially, you can again call this a reconstructive surgery because that's what it is. And now, the other surgical goals is to remove dead tissue, okay, a tumor or an infection, reduce the mortality and morbidity because of the presence of dangerous substances, and then the eventual goal would be to return patient to maximum level of independent function, which ties in with the physiologic end organ. Now, for the patient stump to be able to um, accept a functional prosthesis, the goal would be to conserve the stump length for functional use. So the length of the stump actually helps in better prosthetic sockets that will fit it when artificial limb is manufactured. Um, that statement has gained less importance over the years because modern prosthetics are able to almost incorporate any type of stump. However, it is important to know that the longer the stump is, the better the functional prosthetic um, movement. The steps to deciding for amputations have two options. Okay, either to salvage or to sacrifice. For salvage surgeries, the attempt to preserve the limb is the primary goal. In every decision for an amputation, prior to that surgery, a vascular surgeon consult is an absolute must to see if the vascularity can be preserved. The upper extremities usually are more successful in attempted salvage because they are non-weight bearing. On the other hand, lower extremities are less successful in salvage because they are weight. There are many predictor scoring systems for salvage. This is not important for you to remember, but just to show you, the physicians use many different scoring systems to see if the limb can be preserved. The ultimate decision to perform an amputation is basically sacrificing the limb. So this is the culmination and failure of all salvage options. Everything that can be done to save the limb has failed. Now, it is also undertaken when there is a threat to life from the limb that is being considered for amputation, and it is also undertaken in the absence of any ambulatory potential when a limb uh, is contributing to morbidity of the patient, uh, then the decision to amputate and sacrifice the limb is taken, uh, thereby to reduce that morbidity. Some additional surgical considerations involve each one of this. So the physician has to take into account the healing of each level of tissue, um, and rehabilitation. Is rehabilitation possible? What kind of rehabilitation is possible? Uh, what is the extent of rehabilitation that is possible? These are also considerations because the shape of the limb will contribute to this, the patient's physiologic state will contribute to this, and so on. You will see that residual limb physiology, prosthetic options, emotional status of the patient. And one important consideration is the cost of energy for prosthetic function. If prosthetic function is being undertaken, is the patient appropriate um, for future prosthetic fitment is also an important consideration because it takes more energy to ambulate and move around with a prosthesis. And what are the other alternatives uh, to preserve the limb? Has every alternative been considered? These are aspects that a physical therapist can be asked to contribute to in that decision making process. The surgeon makes a decision whether the surgery will involve a terminal scar or a scar that is either in the front or in the rear. In case of a terminal scar, the skin is incised such that there are two equal-sized flaps created from the anterior and posterior surfaces. These are called fish mouth incisions. The scar in such case will be at the end of the stump, otherwise called a terminal scar. While these stumps look more aesthetic, The end of the stump will be non-weight bearing, otherwise the scar will break down on bearing of weight. Examples of such surgeries are in the upper extremities and sometimes for transfemoral amputations. The other type of surgical incision is one with unequal flaps. There is either a long anterior flap and a short posterior one, which would create a posterior scar, or vice versa, which would create an anterior scar. These scars will allow weight bearing with total contact sockets and can also be end weight bearing. However, it does not have to be an end weight bearing because weight can be distributed throughout the residuum in modern prosthetic sockets. And here are examples of both types of skin flaps. On the left, equal length flaps lead to a terminal scar. On the right, the scar is placed anteriorly by longer posterior flap and a shorter anterior flap. In previous slides, we discussed the incision decision on the skin. Amputations are done with an eye to each layer that is dissected. And the next major layer below the skin is the muscle and then the bone. In elective amputation stage, the muscle cut is done distal to the level of proposed bone division. This creates a longer muscle flap than the bone. These muscle flaps must be stabilized, otherwise they will undergo atrophy within 1 to 2 years. There are two models of stabilization with its inherent strengths and weaknesses. You need an understanding of both. Muscle flaps can be stabilized either with the myodesis procedure or by myoplasty. In myodesis, the muscle flaps and tendons are anchored into the bone using sutures. This is the ideal method because it allows for pull on the bone, thus preserving proprioception and kinesthesia, and is therefore more physiological. Myodesed muscles provide counterbalancing of antagonists, thus optimizing function and reducing complications, for example, contractures. However, the drawback of myodesis is that it cannot be done on ischemic sites. For situations where myodesis is not feasible, the muscle flaps are then sutured to each other. That is, the flexor and the extensor groups are sutured to each other. And similarly, the adductors and the abductors are sutured to each other. This technique is not as physiological as myodesis and can lead to poor future prosthetic function due to both mechanical as well as proprioceptive impairments. Apart from skin and muscle, other tissues are of course divided in the course of surgery. These include the blood vessels, the nerves, and the bone. The blood vessels are carefully ligated to ensure adequate supply of blood to the remaining distalmost tissue. The nerves are always cut much more proximal, which is higher to the site of amputation. This is achieved by pulling on the nerve and dividing it with a very sharp scalpel or knife. The importance of this cannot be understated. A poorly cut nerve due to the lack of proximal cut or dull knife will continue to allow the nerve to grow and create a bulb of nerve tissue at the site of the amputation called a neuroma. These neuromas are painful and prevent good prosthetic fitment and rehabilitation. Often these neuromas require reamputation to try to quote unquote fix the impediment to rehabilitation. However, resurgery is not always helpful. The bone is also cut proximal to the muscle cut to allow for it to grow in length after the amputation and thereby not to create a painful bony end that can cause repeated skin breakdown. Knowledge of these surgical decisions will empower you to understand situations where the patient presents with less than ideal outcomes. The exact surgical site is called the site of election. As has been discussed, there are numerous decision factors to the site of election. We discuss these decisions to ensure that you are in sync with understanding both the way the patient presents as well as to tailor the rehabilitation around the decision. The primary determinants of surgical site of election is bifold. What would be the demands of a functional prosthesis if such were the option, and the site that is distal to the most distal palpable arterial pulsation? The secondary determinant of the site of election is cosmesis, which makes the patient look the best after surgery, since self-image is going to be irreversibly changed after the procedure. Other issues surrounding the site of election is regarding the stump length. If the stump is too long, it is going to be very painful, easy to ulcerate, and complicates incorporation of a prosthetic joint. Imagine a long femoral amputation too close to the actual knee joint. Incorporating a knee joint in a long femoral stump will place it lower than the normal joint on the contralateral side, which will cause major proprioceptive impairments and thereby a challenge to train in rehabilitative prosthetic gait. On the flip side, a stump that is too short will repeatedly and easily slip out of the socket. This goes to prove the complexity of the decision-making of the site of election of the amputation and may be answered by the statement, what's best for this patient at this time? This slide summarizes the elements we have discussed so far. Let's now look at the types and classification of amputation. Amputations can be classified or the nomenclature can be ascribed by any of the following mechanics. It is often after the name of the person who first performed it. It can be based on whether it is a major surgery versus minor surgery. It can be after the stages of the amputation, and it can also be named on the level of surgery. Let's look at each one of these a little more closely. We begin by the amputations that are named after the original surgeon. Amputations are historically named after surgeons who first performed and described them in literature. Not surprisingly, these were often battlefield surgeons or surgeons at times of war. Syme of Edinburgh of Scotland, who died in 1870, was one of the last of the pre-Listerian greats, which means the time before Joseph Lister, who is credited as the father of modern antiseptic surgery. Syme devised the so-called Syme's amputation, a foot surgery still undertaken today, especially in the Third World, due to the retention of the heel fat pad, allowing proprioception and thus very functional residual limb length. All modern surgeons are still trained in the ways of Syme amputation. Similarly, Pirogoff was a celebrated Russian surgeon of the Crimean War and a contemporary of Syme's. He devised the Pirogoff amputation in 1852, which was very similar to Syme's. The only practical difference between the operations was that Pirogoff retained a piece of the calcaneum in the heel flap, while Syme dissected it out. The other surgical amputations listed here are future refinements of Syme's and Pirogoff's, or forefoot surgeries. These surgeries are still done with these same names today and present for rehabilitation to physical therapy. It is important to study the mechanical changes imparted by each of these surgical methods to best understand their unique rehabilitative challenges, and will be covered elsewhere in orthopedics. Amputations can also be named or classified by major or minor criteria. Major amputations involve removal of large body parts, for example, proximal to the TMT or the transmetatarsal joint. Examples of such surgeries are Choparts, Boyds, Symes, below knee amputations, and above knee amputations. Minor amputations involve only small body parts, for example, toes or forefoot. For example, some transmetatarsal amputations or Lisfranc surgery. Amputations may be classified by the stage of amputation. They can be emergency or elective. Emergency amputations are done to save a patient's life, usually after horrific injuries. Provisional surgeries are intermediate surgeries done to reduce infection, allow some healing, and also to save patients' lives. In one way, provisional surgeries can be thought of to be emergency amputations. Provisional surgeries are undertaken in cases where healing by primary intention is unlikely. In such cases, the limb is amputated as distally as the causal factors will allow. Skin flap is sutured loosely over a packing or may be left open, which is called a guillotine. Proximal reamputation is performed when conditions are favorable. All provisional surgeries will need to be finalized as a definitive procedure in the future. Definitive surgeries are planned procedures where the patient's consent is taken and the different factors involved and discussed earlier are carefully planned out. These may involve surgeries undertaken for cosmesis or for finalizing a previously done emergency or provisional surgery. Definitive amputations, therefore, are elective procedures. The stump is carefully shaped with the expectation of assured vascularity and ready for final healing and rehabilitation. In other words, definitive surgeries are elective surgeries. Sometimes a definitive surgery may still need to be revised if any of the predetermined calculations go wrong. For example, if vascularity does not go as planned. In any revision of provisional amputations for definitive surgery, it is almost always will involve a reamputation at a more proximal level. Understanding this is important because accurate rehabilitative decisions are not feasible before definitive amputation level is achieved. A few other points about definitive surgeries. The image shows an emergency surgery without the use of skin flaps. This is also called a guillotine amputation that I referred to earlier and is undertaken as a chopping cut through the limb. The resulting stump is a study in transsectional anatomy. These amputations will undergo future definitive surgery, always as a proximal surgery. However, PT is always consulted right after the initial surgery. Amputations can of course be classified by the anatomic level of surgery. This is often the common way of referring to these amputations. The determinant of the level of amputation and the prognosis for healing are based on all of the following decision matrices. Stop the presentation and take a good look at these. During elective amputation, the level is clearly identified and agreed upon in advance. Determination of level is of least concern during emergent amputations. This is an example of a guillotine amputation of the foot. Here are the levels of upper extremity amputations, and they are self-explanatory. Removal of the entire arm along with the shoulder girdle is called four-quarter amputation. The image here describes a four-quarter amputation from a massive, life-threatening, fungating cancer of the humerus. This image here shows a forearm amputation, uh, the cause and the end result. These are the levels of lower extremity amputations. Removal of the entire limb with the ipsilateral pelvic girdle is called hemipelvectomy or hindquarter amputation, which is not shown in the image. This causes a severe rehabilitative challenge as the patient no longer has an ipsilateral ischial tuberosity to sit upon, far less any stump to fit a prosthesis on. The hemipelvectomy is a debilitating and disfiguring surgery that cannot be fitted to a prosthetic, and the highest rehabilitation would be at the level of a wheelchair if at all feasible by the challenges why the surgery is undertaken in the first place. The hemipelvectomy is different from a hip disarticulation where the hip joint is separated at the acetabulum, but the pelvic girdle is retained. A knee disarticulation is an amputation that is undertaken through the knee joint. Of course, any joint can be disarticulated and would lead to its own specific challenges determined by laterality, dominance of the specific side, and functional limitations. The knee disarticulation is common among other disarticulations and is being presented here. The student of amputations is encouraged to review surgical techniques of other disarticulations and indeed all amputations to gain an understanding of the tissues that were altered, thereby understanding the mechanics of the new stump. The knee is disarticulated by way of a fish mouth incision, which is the name for equal flaps. Thus, the scar is terminal at the end of the stump. The procedure involves the resection of the patellar tendon at insertion, resection of the hamstrings at their insertion, the shaving of the condyles, and then the patellar tendon is pulled into the femoral groove and attached to the cruciates. A good place to look up surgical techniques is actually reading the surgical note on the patient's chart. For the common below knee amputation, consider the following. If there is a terminal scar as shown in the picture, can there be any weight bearing at the end of the stump? Secondly, in reference to the picture, the ideal length of the stump is 5 to 12 inches from the knee joint. This is the ideal length for prosthetic socket fitment. This slide graphically summarizes the amputation levels discussed so far. Let's now discuss the biomechanical issues caused by transfemoral amputations. For all agonists, there are antagonists. As you know, muscles provide balance amongst opposing group of muscles. Without opposition, there would be unopposed action, which leads to contractures and the resulting functional impairments. When muscles are divided or transected, this balance is lost. Due to the loss of this balance, there is stump malpositioning. For example, a very high above knee amputation, or AKA, will lose the insertion of the adductor group, which are typically attached to the femur at the proximal, medial, and distal ends. An unopposed pull of the hip abductors will cause contracture of the shorter abductor group and thereby limit the adduction of the hip. This requires the therapist to identify this problem early at the time of initial evaluation and thereby ensure proper abductor stretching and teaching the patient to self-stretch to prevent the contracture and from future impairments to prosthetic gait. This image shows you the normal biomechanical alignment of the femur. This should stoke your memory from your biomechanics class. Note the mechanical axis shown here and how it is different from the femoral shaft axis shown here and the vertical axis, which is in the middle here. This image illustrates the femoral muscle attachments of the adductors. It is obvious that any level of amputation above a knee disarticulation will lose the biggest adductor of them all, the adductor magnus. This alone will give an advantage to the abductors to pull the stump out in abduction. Higher level of amputation that compromises the adductor longus or even the brevis would compound this problem. The end result is always an unopposed action of the abductors, resulting in an adaptive shortening of the abductors over time, leading to their contracture and a widely abducted hip joint. The prosthetic gait, if feasible, will be correspondingly inefficient. In this section, let us look at the foot and partial foot amputation. As has been discussed before, foot amputations can both be major or minor amputations. Ray and toe amputations are usually minor amputations and will not be specifically discussed. We will focus on the major amputations of the foot. Depending on level, they can be divided into forefoot, midfoot, and hindfoot amputations. The different types are listed on this slide. The forefoot and midfoot amputations are shown in the images for conceptual framework and is important for exam questions in the form of anatomy that would be sacrificed for each level. Note that toe amputations are actually disarticulations. The metatarsal resections include the toes, and the transmetatarsal amputation goes through the metatarsals. Foot amputations are typically treated with shoe fillers with different materials to allow for forefoot roll-off phase of gait. More the loss, the greater is the filler need, and the quality of the filler must serve the purpose of gait. People without adequate insurance may opt for newspaper or similar unscientific fillers, sadly complicating not just the gait but the integrity of the tissue itself for lack of protective features. As stated before, foot amputations are typically named after the surgeons who first performed them. Notable are the Lisfranc's amputation and the Chopard amputation. Lisfranc's amputation involves disarticulation of all the metatarsals and leads to an unstable stump. Chopard's amputation is actually a mid-tarsal disarticulation in which the calcaneus and the talus are preserved. This too causes an unstable stump, which are poor candidates for prosthetic device. Hence, these surgeries may be revised to a hindfoot amputation, but not always. There are a few different hindfoot amputations that you will come across, and you can come across all of these types. They can be classified as either Syme's amputation or analog of Syme's amputation, which are the Boyd and the Pirogoff, and quite similar with some minor changes. Syme's is essentially an ankle disarticulation surgery. Because Syme's amputation remains a landmark surgery, even after the analogs became available, it is important to do a quick review of the same. We will also review the Syme analogs, the Pirogoff, the modified Pirogoff, and the Boyd surgeries. Syme's amputation is usually performed in two stages. The talus is sacrificed, but the heel fat pad is preserved. This is a rather important step in the Syme's amputation. This leads to a more energy efficient gait because proprioceptive nerves rich in the heel fat pad is conducive to knowledge of the orientation of the foot. Gait is feasible with excellent functional recovery for most ADLs, and in many cases, gait is feasible even without a prosthetic foot. Indeed, in third world countries, we know of examples where farmers continue farming activities bare feet after a Syme's amputation. In the first world, however, science is less done with a view to cosmesis and some other factors, prime amongst which is that it makes for a poor anchor for functional foot prosthetics. The prerequisite for a Syme's amputation is that it requires an ankle brachial index of at least 0.5 and the presence of the posterior tibial pulse. The Pirogoff and the very similar modified Pirogoff involves removal of the forefoot and the talus followed by the calcaneotibial arthrodesis. The calcaneus is osteotomized and rotated 50 to 90 degrees to keep posterior aspect of the calcaneus distally. It does preserve the heel fat pad similar to Syme's amputation. The outcome of the surgery allows patients to mobilize independently without the use of a prosthetic device similar to Syme's. The mechanical differences between the Syme's, Boyd's, and Pirogoff amputations are shown here in a tabled format. Additionally, the advantages and disadvantages of each are presented. You will notice at the outset how the Syme sacrifices the bilateral malleoli, thus compromising the rotational stability of the foot. The ankle is completely disarticulated, thus sacrificing the calcaneus. The malleolar loss combined with the loss of the calcaneus leads to shortening of the leg more than the other two types of surgeries mentioned here. How the Pirogoff offers more rotational stability versus the Syme is due to its similarity with Boyd. The Boyd surgery offers substantially more rotational stability due to the preservation of bilateral malleoli. The Boyd surgery is preferred over Syme additionally when the heel pad sensation is less than optimal. Boyd is, however, not feasible in infected feet, and the extra length due to preservation of the malleoli is detrimental to the height and function of the prosthetic foot. All hindfoot or partial foot amputations that have no ankle motion are biomechanically similar to Syme's disarticulation, except that due to limited length, they are poor candidates for commercial footwear. The loss of the forefoot lever arm and its associated bony architecture and musculature leads to substantially reduced plantar surface, thus reducing the weight-bearing surface of the foot. And the loss of active pronation and supination during gait, along with absence of active push-off phase, lends to its challenges. Consequently, gait is weight-based, slow, and has poor energy efficiency. This slide shows you all these discussions on foot amputations from a different perspective. Note the length of the limb loss when compared in this fashion. This slide is better intended for your P&O lecture, but I will make a reference to this since we are on the topic of foot amputations, which have some unique challenges from a prosthetic standpoint. All hindfoot and midfoot amputees experience same prosthetic limitations as Syme's, while the residuum contained within the shoe standard footwear cannot be possible because the stump end is literally a peg. Only specialized prosthetics, which are large and bulky to effectively protect the very small plantar surface, can be used. These obviously cost significantly higher. Best socket option for these hindfoot surgeries involve bivalve sockets, which are inherently weaker than regular one-piece sockets. Finally, there is a massive loss of the push-off mechanism due to no push-off mechanism within the footwear. Thus, the footwear only serves two purposes: protection of the residuum and cosmesis. This is the summary of the discussion regarding foot amputations of this section. All surgery is prone to complications. Amputations constitute major surgery, and therefore there are tons of complications to understand. It is better to classify these complications from different causation to have a better comprehension of their occurrence. Before we embark on studying the complications, let us clarify the basic terminology we will use. After the process of amputation is complete, the remaining limb can be called the terminal limb, or stump, or residuum. Majority of these post-surgical complications in amputations deal with the stump. However, there are non-stump complications as well. Complications in amputations can be grossly separated into early versus late phases. Early complications are soon after surgery and can happen in days or weeks after the surgery. Late complications can be weeks to months or even years after surgery. Let's take a look at each one of these. Early complications of amputations can be divided into surgical, breakdown of flaps, phantom limb, and gas gangrene. Surgical complications is typically a massive delayed hemorrhage. It is not common but can happen. I cannot go into the elaborate discussion on delayed hemorrhage at this time, but it is not the same as intraoperative hemorrhage. Skin flaps usually break down if there is persistent ischemia or the lack of blood supply, or if there has been suturing under excess tension, for example, if there was swelling over which suturing was performed. Phantom limb is an abnormal sensation that is the persistence feeling of the presence of the absent limb following amputation. This is distinctly different than phantom pain, which we will discuss later. And finally, gas gangrene is the development of life-threatening infection in the stump by bacterial agents that produce gas, commonly from Clostridial and streptococcal infections, while other bacteria can also be responsible. Late complications of amputations can be classified by the layers which are involved. They are mentioned in the slide and are self-explanatory. Some terms, however, I am going to explain here. Dog ears refer to the persistence of projections from the ends of suture line that look like dog ears, hence the name. It is therefore a term used to describe a point or fold at the end of a skin tightening incision and is a common term in any reconstructive surgery. This usually is a reflection of poor surgical technique and eventually causes difficulty of prosthetic fitment and allowed development of ulceration of the stump end if left unrectified. Typically, resurgery would be needed to remove the dog ears. Neuromas refer to unwanted and abnormal growth of severed nerves that bunch up at the distal end of the stump and become a source of pain and irritation, along with the development of phantom sensation and, more importantly, phantom pain. At this point, it is important to differentiate between phantom sensation and phantom pain. Phantom sensation refers to the persistence of the feeling that the excised limb is still present when it is not. The patient might state that I feel the leg or parts of the leg, for example, the great toe is still present when it is clearly not. Remember that it is not hallucination, but rather the patient really feeling the leg. Phantom pain, on the other hand, is a more serious matter, where the patient feels pain in the portion of the limb that is no longer present. This is a very serious matter, where the patient feels pain in the portion of the limb that is no longer there. Uh, and it poses um, additional challenges. Imagine that phantom sensation can just become a new way of life, but it does not interfere with activities of daily living. However, phantom pain by itself can be severely limiting to the usual way of life and greatly debilitating in that it might consume all of the patient's focus and attention and prevent them from activities of any sort. They might need resurgery and not always greatly successful at that. Neuromas and phantom pain often signal poor surgical technique if elective or severe trauma-based amputations. Usually to blame are blunt dissection of the nerve. Remember, I said before that the nerve should be cut by a very sharp scalpel and under tension so that it retracts into the proximal limb. However, it is possible that it is not done or the amputation happened under trauma, preventing smooth dissection of the nerve. FFD is an abbreviation used to signify fixed flexion deformity in the joint proximal to the stump. These are common due to muscle imbalance created by the amputation. In the hip, a fixed flexion deformity occurs due to high above-knee amputation, which feature a very short femoral stump. In the knee, a fixed flexion deformity occurs due to high below-knee amputations, which feature a very short tibial stump. In certain hindfoot and forefoot surgeries, a severe plantar flexion deformity occurs known as an equinus deformity. Equinus means like a horse. If you're not already aware, horses stand on the end of their on the end of their middle toe, kind of like a ballerina. But the ballerinas, of course, stand on all of their toes. Horse hooves are really their middle toe. Hence, the name equinus refers to plantar flexion deformity so severe that the patients are literally up on their toes. This is, of course, due to unstable residual components in the foot. It is common in surgeries, for example, in Lisfranc's amputation. The other complications mentioned here are self-explanatory, I would think. It is important to mention that following amputations, patients may still perish from complications of comorbidities. In such cases, the typical at-fault conditions are uncontrolled diabetes mellitus, cardiovascular disease, or renal disease. In this section, it is a brief on amputee rehabilitation. Let's review the factors of concern in the success of amputee rehabilitation. All the factors mentioned here are essential for successful rehabilitation of an amputee. There is literally no one factor that takes a higher importance. In other words, they're all equally important. One particular one I would like to reiterate, having previously mentioned it briefly, is that length matters. Length matters when it comes to issues of residual stump. In most cases, having adequate length is helpful, but not always. A stump that is too long or too short are both prone to complications in rehabilitation. Therefore, it merits a deeper look, as we will discuss in the next slide. A prosthetic leg takes more energy to manipulate when actually done by the patient. This can be explained by the fact that the additional weight of a conventional prosthetic must be moved by muscles that are greatly altered by the surgical process. In fact, there are far less muscles to move far more weight added on by the prosthetic. In that arithmetic, the energy cost of a prosthetic leg user can be stated to be inversely proportional to the length of the residuum. In other words, shorter the stump, more is the energy used and vice versa. Therefore, for the least energy consumption, a longer stump is generally preferable. A longer stump allows for better prosthetic joint function, but it should not be so long as to impair the functioning of the joint. A longer stump allows for preventing localization of the weight, with more available surface area for distributing the body weight being borne by that residuum. The mechanics of holding a prosthetic socket onto the patient's stump requires a mechanism known as suspension. There are many suspension techniques, some better than others. A longer stump generally allows for improved options for suspension. A longer stump also allows for far more sophisticated componentry. Thus, in summarizing, stump length matters when we are talking about the rehabilitation of patients with amputations. This slide shows you an estimate of the metabolic cost of energy to move with a lower extremity prosthetic computed per minute by the level of amputation. Pause this presentation and get an appreciation of how the cost changes with longer amputation stumps. What happens if the cost of energy to move is high due to whatever reason? A person will compensate a high cost of energy to achieve basic function. How does that change gait? The walking velocity will be reduced to allow for conservation of energy. Another bigger problem that will result is that without compensatory adjustment to per minute energy expenditure, anaerobic mechanisms will develop with the production of lactic acid, and this will lead to early fatigue and thus reduced endurance. It is important to have a deeper understanding of these features. Rehabilitation of amputees requires significant resources. The physical therapist, the occupational therapist, the prosthetist, the physician, and family all play a crucial role. Insurance is a must as prosthetics, even the conventional ones, are very expensive. Certainly, newer prosthetics with advanced lightweight materials, for example, carbon fiber and computer-controlled joints that help with the cost of energy and more natural gait will add thousands of dollars to the bill. The rehabilitation of patients following amputations follow three distinct stages. Immediately post-operative, which occurs in the hospital. The post-acute recovery stage offers an option between home versus institutional recovery, and the last stage is that of the pre and peri-prosthetic gait stage. It is important to understand the acute care hospital goals because they are essential to understand where the patient is discharged to after the acute hospitalization period is no longer needed. The goals of acute postoperative phase are listed here. They all lead up to culminating in the planning for discharge and discharge destination. Let's look at each one of these more closely. Pain control is paramount after amputation because the surgery is very painful. Without adequate pain control, any semblance of rehabilitation is virtually impossible. The PT techniques involve modalities and counter irritation. Cryotherapy using ice bags or more advanced technology is the most effective modality. Counter irritation refers to rubbing the residual stump. However, both these techniques involve that the stump is available for access, at least through soft dressings. Some stumps may be in hard, non-removable compression system that will not allow cryotherapy or counter irritation. Regardless, these two techniques may not provide sufficient pain relief. Hence, a more robust type of pain relief system is needed. The most effective pain management is therefore pharmacologic. Use of opioid pain medication offers the best pain relief for rehabilitative purposes. These are controlled substances, and if you need a pharmacologic refresher, see my controlled substances lecture that I am appending to the notes area below. I am also including a mind map of opioid medications that can be employed for pain relief. Educating the patient is paramount as amputation involves a complete change of body image and requires great number of parameters to be addressed even outside of the time spent with therapists. First thing to educate is on expectations of recovery. This is more important than you would first think of. It is common for surgeons to assure patients that they would regain their body image and gait function with PT in no time. This cannot be further from the truth. It takes months and years before that can happen, and in many cases the patient may never be able to walk again. Ask for the patient's goals and compare with what is physiologically possible for that patient specifically. Often the goals do not match the physiologic possibility, which leads me to reiterate that it is important for good patient selection for rehabilitative purposes. Educate the patient on evidence-informed goals. Talk of feasibilities, timelines, and provide moral and psychogenic support. For either of them, do not promise an outcome that may never be achievable. Talk in possibilities rather than absolutes. Stump care begins day one. The goal of stump care involves management of incision and residual limb volume containment. The residual limb is swollen as a result of post-traumatic inflammation, and the residuum is full of water. It needs to be compressed to achieve a final shape that is called the ideal stump. An ideal stump is conical, fully shrunken, and able to bear weight eventually. The final ideal shape can take months to achieve and therefore clear that the patient cannot directly proceed from the hospital to a prosthetic stage. There are some caveats for this statement. Some patients may be fitted with a temporary prosthesis right on the surgical table if they fit some specified criteria. Those patients achieve prosthetic function sooner. They typically require to have good blood supply or vascularity and are usually younger in good physical shape. Therefore, another important goal for stump care involves hourly vascularity check. The presence of a distal pulse or color in the stump is essential for everyone, but more so for those with known dysvascularity. Patients are taught in contracture prophylaxis, which means prevention. For all lower extremity amputations, patient must practice prone lying for at least 15 minutes and repeat 2 to 3 times daily to prevent hip flexion contractures. Same goes for knee joints in below knee amputations. They need to be propped up on pillow without any support underneath the knee. It is essential to institute full range of motion at proximal joints 2 to 3 times daily and 10 reps each joint that can be done by the caregiver until the patient is ready to do it themselves. As mentioned, we talk of prosthetic criteria and we discuss the actual requirements and timeline to prosthetic stage. We tell them that when the stump is ready, we begin so-called the pre-prosthetic stage, and then later on the prosthetic stage after the limb is properly shrunk, a process that can take months. Some patients are educated on the highest function to be from a wheelchair level. Non-stump complication management involves these three areas. Pay attention to pressure prophylaxis for those who cannot turn themselves. The use of pressure relieving mattresses and bedside turning schedules are very helpful, but may not be available outside of ICU environments and may require manual assistance. Such schedules are implemented by nursing, but if they don't have a system, you will need to work with nursing to implement this. Pulmonary prophylaxis involves maneuvers to avoid pneumonia or poor oxygen saturation. Institute a deep breathing and coughing schedule. For deep breathing, use an incentive spirometer that must be performed in sitting. For coughing, pair that with an a cappella or some kind of a flutter valve. Sit patients up regularly and teach the caregivers to do so as well. Younger patients will be up and about and don't need your intervention, but the older and infirm will. Upright positioning helps with orthostatic conditioning and thus prevents patients from passing out when upright. Stump management involves wrapping, as mentioned before, and will be taught in a lab for this purpose. This particular image shows how an above knee amputation is wrapped. Um, Not every patient will require such wrapping, and in some patients it might be even contraindicated, as we will review later in the lab class. Functional mobility is always an important concept and component in any rehabilitation. In amputations, we can have two types of patients. One type can generally wake up from surgery and within a few hours get up and move around by themselves using a walker or wheelchair or both. Generally speaking, these are our younger patients who are otherwise healthy and in good physical shape. This actually happens to be a great many of the amputees. The other type of patients typically are more debilitated, especially when the patients are older and debilitated from comorbidities. These patients are the ones that typically need continued rehabilitation before they can go home. In younger patients, we verify their abilities of bed mobility, transfers that involve single leg stands, and bed to and from wheelchair. We evaluate their out-of-bed mobility by wheelchair or walker or crutch. Most usually, they take to single stance gait rather well and do not need intervention to teach. Sometimes we may have to deliver them first-time crutches and teach them swing through crutch gait, which takes only the first evaluative session or maybe one more session. These are easy rehabs. It is important to remember that they all need to clear stair climbing function to go home if they have stairs to negotiate at home or apartment without elevators. The older clients with debility and impairments of all function require active intervention and a plan of care that addresses their specific impairments. Discharge planning is interesting in amputees. It is common to think that an amputee needs inpatient or perhaps subacute rehab in an institution. However, this cannot be further from the truth. Fit and active amputees who achieve functional mobility goals in the acute care setting and are independently ambulatory with walker or crutches can typically go home. Debilitated patients who are not independent with basic functional mobility by the time of discharge need to go to rehabilitation. There can be case-by-case caveats to this unwritten rule. Remember, the patients will not be ready for prosthetic for months. If a patient is ambulatory, there is no further rehabilitation need except for the patients to continue to work on compressing their stumps until it is ready in ideal shape for the prosthesis. At that point, they can move into the pre-prosthetic stage, typically at an outpatient physical therapy clinic. I have created an algorithm for discharge planning that I will link from the notes area of this lecture. In this section, I will discuss some special populations of amputees, namely children, but others by nature of the amputation surgery. Children are not young adults, as you have seen in cardiopulmonary and other specialty medical conditions. The problems in child amputees are uniquely their own, and their rehabilitation expectations and trajectories are different. A separate recognition of these aspects beg to be discussed on the premise of this presentation. Pediatric amputees face numerous unique physiological challenges. Their bones are in the development phase and see both interstitial as well as appositional growth that helps in increasing the length and breadth of the bone. The functional demands of the residual limb and prosthesis are therefore different and change with the growing child. Since body image an integral part of the psychological growth of a child, the limb loss can be of massive challenge, but interestingly, children take to this challenge well. Children needing amputation often need multiple limb amputations. They also require multiple revisions throughout the growth period and maturity due to changes discussed already. The primary goal of amputation in children is to convert to a functional stump that can accept a prosthesis. It is perhaps a silver lining that juvenile amputees very rarely experience phantom limb pain, but like all generalizations, there are always exceptions. The etiology of amputations in children is quite different than that of adults. The predominant cause in children is that of congenital malformations. Trauma is the next, and then infections and cancers. Here are some examples of congenital causes of amputations. Arthrogryposis multiplex congenita, which is shown in picture in the next slide, is a condition where children are born with abnormal limbs with loss of flexure creases, stiff joints, and impaired mobility, where the limb is a liability rather than a strength. Teratogenic drug-induced conditions such as amalia, phocomalia, etc. is another congenital condition where amputations may be considered. Congenital constriction band syndrome is where a baby is born with constrictive collagenous bands around their limbs which restrict movements. This image shows a child with arthrogryposis multiplex congenita. Note the legs which show the condition. The goals of amputation in children involve best practices shown here. It is important for preservation of length, just in any amputation. It is very important to preserve the growth plate, which have not yet fused and allows both appositional growth as well as longitudinal growth of the bone. Whenever feasible, it is preferable to perform disarticulations instead of transosseous amputation. If feasible, the sparing of the knee joint allows for a more normal growth and prosthetic function in the future. It is also important to keep the proximal limb stabilized with minimal muscle imbalance to control for contractures as the patient child grows. We will end this presentation by talking about two unique amputation surgeries, often undertaken in the pediatric population, but can also be done in adults. The first one is the tibial rotationplasty, also known as the Van Ness procedure. The second is the Krukenberg procedure. Both these surgeries are not just amputations, but they have a functional and unique twist, which is rather literal in the case of the Van Ness procedure. Let's take a look at each one. This image is the tibial rotationplasty, often done for pediatric bone cancers, for example, osteosarcoma or Ewing's sarcoma, both of which occur near a child's knee in the lower part of the femur or the upper part of the tibia. This rather unusual procedure preserves the lower leg and attaches it to the femur, then uses the ankle joint to work like a knee joint. The bottom of the femur, the knee, and the upper tibia are surgically excised. Then the lower leg is rotated 180 degrees. thereby the name Rotationplasty, and attached to the femur. The foot is now found at the end of the thigh, pointing backwards. The role of the physical therapy professional is now paramount to retrain the ankle and foot to work as a knee joint. However mind-twisting this may sound, this is very feasible and functional workaround to preserve the leg and allow for a fairly high level of function. I am including links in the notes area to show you examples of this, the functional abilities that are possible after this procedure. I urge you to take a look at that. Unique amputation surgery is the Krukenberg procedure. The Krukenberg procedure, also known as the Krukenberg operation, is a surgical technique that converts a forearm stump into a pincer. It was first described in 1917 by the German army surgeon Hermann Krukenberg. It remains in use today for certain special cases, but is considered controversial and some surgeons refuse to perform it. While rare in the United States, it is done in some countries for its rather functional outcomes. In this complementary surgery to below elbow amputations and in cases of congenital absence of the hand, the radius and ulna are split to create a pincer, as shown in the image on the left. This pincer, after healing, can be retrained to perform even fine motor skills powered by the pronator teres muscle that is strategically placed. The function can be fine motor skills, for example, writing, picking up a glass of water, and other work. People do live productive lives after this surgery despite its rather unusual appearance. The reason that the surgery is often not done in the Western world is the availability of advanced prosthetics. Even then, sometimes this surgery can be seen in the Western world in blind patients with bilateral upper extremity amputations due to preservation of tactile sensation. But in the third world countries without access to expensive modern prosthesis, for example in South America, this surgery is more common. The one important problem with this surgery is the surgeon's training and skill. The split should be exact. If it is too little of a split, the functional excursion is not going to be enough for retraining tasks. If it is too much, each bone will become flail. Either options are going to result in a non-functional forearm that might be required to be re-amputated. The success of the Krukenberg procedure depends directly on the strength of the pronator teres, the sensibility of the skin surrounding both the ulna and the radius, the elbow mobility, and mobility of the ulna and radius at the proximal radio-ulnar joint. Individual patient expectations and motivations, although more difficult to assess, probably play a major role in outcomes as well. The patient retains the ability to use a prosthesis despite this surgery. Early performance of this surgery in life also provides a greater acceptability and success. And that brings us to the end of this presentation. All references are provided in the notes section. Do respect all copyright laws. For my additional video lecture series, please subscribe to this channel. Thank you.